Clarence, I have a very important guest today. You've seen him before. He is Clarence Pierce, the CEO of Hamilton Community Health Network. Clarence, your service has proven to be very beneficial to Hamilton Community Network, expanded and its expanded population serving its clients over a period of extreme and diverse change, as evidentiary data will show, and without scandals, improprieties, and indiscretions. But now hear this: the average life cycle of a CEO of an FQHC is 73 years. And Clarence, you have lasted more than three times that. Now I need to go to my my monologue here to show why this is critical. I am Henry Hatter, one of the few remaining conservative talk show hosts in Flint, Michigan, the home of General Motors and the UAW, as well as Hamilton Community Health Network, which exemplifies how free enterprise can benefit Black Americans. And here's how. Flint has historically played a crucial role in uplifting the middle class, demonstrating the potential of a free market. This transformation was not by chance. It required strong leadership to create equal opportunities in wealth and education. I am both your critic, Clarence, and an advocate. I may regret this because I'm equally across the board as the emeritus. But I recognize that my voice is just one of among many voices. I strive to adhere to the data and resist autocratic tendencies, valuing the principles of the Constitution. Although I am a lifelong Republican, I see the party adapting to a diverse society that many people embrace. The GOP is gaining momentum, and it is important to acknowledge the significance of untapped resources that sometimes the other party has underestimated. However, we must remain cautious. Thank you. I'll end my monologue there and go back to you, Clarence. As I said, Clarence, you have served on Hamilton Community Health Network for three times longer than the average CEO. Clarence, how do you do it?
Well, Henry, I think it starts with hard work and patience because it doesn't happen overnight. I mean, you have to first of all make sure that your board is in tune with your vision and you're in tune with their vision. And we work together to hopefully be successful in whatever our objectives are. Now, with me coming in with a situation that was, I would say, in dire straits, uh, we had some work to do out of the box. And when you're coming into a situation, your board doesn't know you, you don't know them. And so, first, we have to develop a trust relationship. You know, they have to trust me in what I'm doing and my knowledge and my vision to where we're going. And I have to trust that they're going to give me the latitude and the support that I need in order to achieve those things to make us successful. And so we have been able to do that. It was slow going initially, and that's what I mean about patience. These things don't happen overnight. It takes time, and the hard work pays off in the end. But it is a slow process working together and developing a staff that will be, I think, extremely important to the success of the organization. And we have been able to do that.
And that's very evident, Clarence. Um, Now, you received funding from the 330 grant, But you also receive some state funding from other discretionary sources or mandatory funding from the state. How then is that considered federal money?
Well, now the state money is not federal. That comes through the Department of Health and Human Services, uh, and we don't get a lot of state money. I mean, we have been able to access some dollars for the project we have going on now on the east side of Flint. But typically, our funding comes from the federal government under the 330 program. And part of that includes our homeless program. So we have what is considered to be the 330E and the 330H, a small amount of funding for the homeless, but most of our funding is in the 330 for primary care services.
Yeah, but there's another source of funding that you receive. That's the funding that you make
Mhm.
uh, from the services that you provide to the community.
Yes, that's
Uh,
what we build,
yeah,
and
yes.
and we generate probably 95% of our revenue through patient billing, and about 65% of that comes through Medicaid, then another 15% Medicare, and then of course we have some uninsured and some private pay. But the vast majority comes through the Medicaid program.
You know, Clarence, you've done a great job with Hamilton Community Health Network. But many times when you have these highly functioning organizations and you're doing well and very successful, sometimes you can, things will occur that you're completely unaware of that could damage the reputation of the CEO or the institution itself. How do you avoid that?
Yes, well, we maintain an open door policy, Henry, and we ensure that everyone who comes in understands that open door policy, and we're not trying to hide anything from anyone. You know, we have our various regulators who we have to report to on a regular basis, federal government and the state government, and we have our board that is in tune into what we're doing, particularly financially. And so we like to be what I would consider to be an open book. You know, anything that anyone would like to know as it relates to what we're doing, we're happy to show them and to tell them what we're doing at Hamilton.
Well, and that's how you want to be. You want to be um, apparent,
That's
transparent.
yes,
Okay. And I believe that you've done that. And that would lead to a long legacy for Hamilton. And that will leave a great testimony for you as the CEO. Um, Clarence, what is the role of the CEO?
yes. Well, the role of the CEO is to, I would
I
say,
should say CEO president, sir.
okay, okay,
Make that distinction.
yeah,
Okay.
okay. Uh, but it's to lead the organization, to direct the workforce, working with the regulators, the board, and the community at large. You know, one of my biggest responsibilities is to ensure that our program is safe, that the healthcare we provide is safe to the public, and that the providers we hire are quality providers that are licensed and credentialed with our payers, and that our staff is qualified to perform their roles. And my role is to lead that in a way to make us successful.
How important is stability? You know, an organization can vibrate itself to death and go out of business. How do you maintain stability? How do you do it?
Well, stability is important, financially in particular, because the old saying, no money, no mission, is so true. So we focus a lot on maintaining our productivity, uh, whereby we work with our providers. We have a limit that we work with, a limit whereby we determine what makes us break even. We need to break even financially in order to sustain what we're doing. And that's very important. So we meet on a regular basis and we discuss the productivity where we are, uh, what our plans are to ensure that we can meet those objectives. The other thing is making sure that we can recruit and hire good quality providers so that we can maintain our stability. And that's mainly what we try to do, Henry. And then, of course, we have our support staff who is critically important to making sure that patients who come in for services are treated with the dignity and respect that we require, that we mandate. And so all of those things working together is what makes us a successful, stable organization.
Well, Clarence, I'd like to have you compare and contrast the role of the CEO president with that of the board chair. What's the distinction? How do you get along? How are responsibilities divided so that they don't, one does not usurp the power of the other?
Mm. Well, the board, is responsible for the board and providing the leadership for the board itself. The two positions are distinct in that the CEO is responsible for the day-to-day operation of uh, the corporation, which means directing the workforce and ensuring that we are in compliance with all of the regulatory requirements. And the board provides oversight for uh, the CEO and no relationship to the staff itself. I'm the only employee that reports to the board. The rest of the employees report to the CEO, and that makes the distinction. The board chair has no operational responsibilities within the corporation, just oversight for the board and oversight for the policies and procedures to ensure that the CEO is carrying out those policies and procedures uh, in a way that is in compliance with the program.
Do you ever have any um, points in each of time when there's conflict between the board and the CEO?
There have been occasions, Henry, where sometimes there tends to be a loggerhead, if you will. Okay, uh, but I think what that I try to do, that not everybody works like I do, but I'm one that try to be a peacekeeper, while at the same time trying to make sure that we all understand our role. Where you tend to run into problems is when people start to operate outside of their responsibilities, and that can create, issues within the operation. And so, what I try to do is one, go to the compliance manual. The compliance manual spell out what the responsibilities are for the board and for the CEO. And so, when you can show somebody in writing, well, this is your responsibility. It's not me telling them, you know. And I think that's the distinction. Some people want to tell somebody what you should and shouldn't be doing. I like to show it to them in the compliance manual, and I think it means much more. Now, sometimes people don't want to adhere to that, and so we try to find some uh, common ground that we can work through. Keeping in mind that no board member has ultimate authority over the program or the board. And so they need a consensus within the board in order to achieve anything. So if it turns out that we can't come to any kind of agreement, then that's when it's time to take it to the full board and let them be the arbiter, if you will, as to what may be going on. Uh, because,
As I understand it, Clarence, you have two sources of authority, maybe three. One are the rules
mm,
from Washington,
mhm,
okay? Two are Robert's Rules of Order.
yes,
Do you go by both? Oh, and your own, um, you have your own documents there,
on internal
guiding.
policies,
Yeah,
yes.
yeah, yeah,
Mhm,
you have your own guidance. So there you have three sources of authority.
mhm,
There should never be any conflict. There may be misunderstandings
yes.
or stuff like that.
Well,
And
you're right. Now, Henry, I think the Robert Rules of Order
mhm,
are basically giving you the outline for running the meeting.
mhm,
When we start talking about responsibilities,
that's right.
now,
That's highly, it should be highly defined.
yes, that's
Board responsibility versus the CEO's responsibility.
yes, and it is, and it is.
But there are places where you might have to, they converge. And this is where you're likely, and it's good, maybe once in a while to have those kind of conflict.
Yeah, well, where that typically will come up is if, let's say, you are advocating for some project or you're advocating to do something in particular, and there may be some disagreement, not only with the board chair, but it could be with other board members. And so, what I try to do, Henry, is make the case. I get the facts, bring the facts to bear, point them out, and then let the board decide, what do you feel is the most appropriate uh, road to go. Now, I'll make a recommendation. I'll put a recommendation on the table, and then it's up to the board to decide and vote on whether or not we want to go that direction or we want to go some other direction. But I think the CEO is responsible for doing the homework, getting the facts together, bringing it to the board with a uh, recommendation because you know they will have done the homework, they will have done the research, they will have made every effort to bring everything to the table for the board to make the decision.
Well, and that, now you can see, folks, how Clarence has survived three times longer than the average CEO of an FQHC. Uh, he's walked you through a process that he uses to reassure the board and the system that it has to work according to the rules that they're given. Robert's rules, your policies, and the guidelines from Washington, right?
That's correct.
Okay,
That's
thank
correct.
you. Clarence, uh, who is your audience? And how has that audience changed over the years with respect to age, race, and gender? Now,
Mhm,
we work in a situation where we don't focus on race or gender
mm-mm,
or wealth.
no,
You have to meet the needs of the people that your grant requires you to meet
mhm,
without fear or favor.
that's right.
Okay? So now, who then is this audience?
Yes. Well, to give you a good idea, Henry,
I
when
mean,
I
your client.
yeah,
I'm sorry, not the audience.
yeah,
The audience is listening to us.
yeah, right. Well,
Thank you.
uh, when I started, Henry, we had what like four sites. I think we shared the health department on the south end of Flint, uh, and we had just recently rented the North Point facility, and then we had our little uh, uh, what we call administrative office, where we had the administration in the basement and had the health center on the first floor in the old credit union where we
Yes,
first
yeah,
started.
yeah,
Yeah.
in the
And,
dungeon.
and yes,
Yeah,
right. And then we had our standalone dental.
yes.
Well, at that point, we were extremely small and we were financially, uh, in trouble.
Mhm.
We had lost a number of patients. I think when I started, we had maybe 50 employees. Uh, our patient numbers were down in the about 5,000, and we had a lot of work to do. And so, out of that, we were able to expand our services. We expanded because of the need. Once we got our financial house in order, because we had to do that in order to be able just to pay the bills and make payroll. So once we got our financial house in order, then we could look at where the need was. And we knew that we had a lot of need on the north end of Flint. We knew we had a lot of need on the south end of Flint in the Burton area. And so we began to expand.
Those were mandated areas by zip codes.
That's correct.
48503, 48504, 48508,
Yes.
48505.
Yes.
Yeah.
All of that
But
was
now you've expanded tremendously. You don't even look the same
well,
anymore.
well, it was all in our scope.
Yeah.
You know, what we have to do is anytime we expand, we have to include
Sure.
it in our scope of services, which means that it's in our territory, if
Mm.
you will. And so we can't just go to, say, Detroit and set up. It has to be
In the needed
defined,
area.
right? And we have to define that up front by submitting an application to say, okay, we want to expand into this area or into that area, and then the feds will approve it. So we were already uh, uh, in that scope. And so it was less difficult for us to continue the expansion. But once we got financially in order, we realized that we needed to do something in Burton. You remember when we shared the building with the health department? We had outgrown that for a long time. And so we were able to secure a building right next door and renovate it and start up services there. With 26 new exam rooms, we had 10 dental operatories, we had behavioral health services, and that site immediately became extremely busy. So much so that we have now purchased the old health department building right next door
Mhm.
because we have expanded to that degree. And also on the north end, we built a brand new facility, the 31,000 square foot facility that houses everything. I'm talking medical, dental. We have a vision program in there. We have a pharmacy in there. We do specialty services, urology. We
It's a
have
one
women's
called a
health.
one-stop shop,
A
isn't it?
one-stop shop, truly a one-stop shop.
Explain to the audience what you get in a one-stop shop, if you can do it in 50 words or less.
Okay. Well, we put it in the context of say, a single mother with three children, and the mother need her services, the kids need theirs. We have the bus stop right in front of the clinic. So she can get the bus right in front of the clinic, come right on in, get services for everyone, and then get her prescription on the way out. One stop, and the bus stop is right there. So instead of going to 3 or 4 locations for herself, taking the kids to another location, picking up her prescription at another location, and then getting a bus, you can do it at one stop.
But you haven't named the services. So, for example, that you have right there in that, how many square feet? 500,000?
31,000.
31,000. But look, you have dental,
Have dental,
you have vision,
have vision.
you have, and of course, primary care.
Oh, medical, yes.
Yeah, medical. And what else do you have?
We have
You're
pharmacy,
teaching,
yes.
and you have,
Behavioral health,
yes, all of those services
yes.
right there at once. So if a
Urology,
person,
and we have a relationship with the University of Michigan.
Yeah.
They bring in their uh, van once a month to do mammograms for our patients free of charge.
Okay, Clarence, we got to kind of speed it up because
Okay.
um, we, when I asked you that question, who was your audience? I was hoping that you would, with respect to age, race, and vocation or whatever, I
And we
was
see
hoping,
all disciplines in it,
yeah,
from
yeah, but
infants to
you have grown. Now, remember those zip codes that we talked about 48504,
yeah.
48503,
Mm,
48505, and 48458.
mm.
Those were areas where most of Black Americans live.
Yeah, yeah,
But now I ask you, who is your audience? You've
yes.
expanded to Clio, you've expanded to Flushing, you've expanded to Lapeer. Now
Mhm.
you're in
Whitmore Lake.
Whitmore Lake. You've expanded and you picked up a, a whole new population,
Yes.
segment of a population,
Mhm.
which means that you're relevant to healthcare
Yes,
and you're meeting the mission
that's
that
right.
you, uh, FQHCs, me, you
Mm,
don't determine people by their race or
that's
age or anything like that. You've
right.
expanded into those areas. And not only that, but you found new sources
Mhm.
of wealth in people who have insurance.
Mm,
Now, most of the people, some of the people that you served in the old days didn't have much insurance.
mm,
They were the ones in the center city. But now you've gone out in these other areas where people have this insurance and you're bringing that into the mix to reduce the cost of treatment for any one
mm.
condition, right? What do you
Well,
call it?
Henry, what we found is that the need is everywhere.
Yes.
Particularly when you go into the rural communities,
Mhm.
they have significant need. Like you take Whitmore Lake as a good example. Now we moved into a new clinic in Whitmore Lake in collaboration with the University of Michigan and the local residents in the community about a year ago. And we have been able to do an agreement with the transportation system down there where they are providing transportation free of charge to the residents who live in the community. So that's going to help us. It's going to help them. Uh, and when you talk about the expansion, when we look at where should we go, we want to go where the need is, where people really need the services.
Yes.
Access to health care should be something for everybody. It doesn't matter what race, what gender, who
Okay,
you are.
Clarence, let me ask you this question. Then this is rhetorical, and it's
Okay.
um, now Washington says it doesn't have all the money it needs to meet this tremendous demand for healthcare.
Mm,
As you know, healthcare is 17.6% of the nation's GDP for for Medicaid and Medicare.
yes.
And yet the defense budget is only about 2% of that. Normally, defense budgets are the big budgets and everybody's around the world. But healthcare takes up 17% of our GDP
Mhm,
and it's growing. And the fear of people who study this stuff
mhm,
is that the country will collapse due to the financial burden of healthcare. And the people who need all of this healthcare is growing because the population is growing
mhm.
and the resources are declining. So this is over time, this will be uh, a prescription for disaster. How do you how do you react to that?
Mhm. Well, Henry, that's why I think community health centers are so important. I mean, we have shown that we are the answer to that problem. We save the federal government billions of dollars uh, because before you had health centers playing the role that they play today, most people went to the emergency room for their primary care.
Yeah,
and that is extremely costly. But more importantly, it backs up your emergency room so the true emergencies can't even get in. And so now you're impacting everyone's care and it's more expensive. And so I think that the community health centers are the answer. You can get people in primary care. When someone goes to an emergency room, all you're getting is episodic care, whereby we're going to treat whatever ails you. If you're a diabetic and your sugar falls low or high, we're going to bring you in. We're going to treat that. We're going to send you right back out there. You know, there's no follow up. There's no treatment. Whereas with the community health center, we're going to bring you in. We're going to get that blood pressure down or the diabetes in control, and we're going to have you coming back, and we're going to provide you with the things you need. We're going to give you on our 340B program where you can get your medications at a much reduced price, and it's going to be much less difficult for you to get that problem under control, and then for us to continue treating it, which is going to lower the cost. Because now, instead of you having an episode, when you go back out in the community after they deal with that first problem you have, and you're going to be right back in there in a month or less for the same problem, and it's like a merry-go-round. Whereas we are going to get you in treatment and get you taken care of on a regular basis, and in the end that is going to save the taxpayers billions of dollars.
So what I hear you saying, Clarence, I believe, is that FQHCs, at least Hamilton, by experience and knowledge, because you're hands-on, that you focus on preventative health care rather than episodic care.
Absolutely.
Explain that.
Well, again, Henry, when I say episodic, I mean uh, when people have even a cold
Mhm.
that they may think is uncontrollable, they go to the emergency room. Well, you shouldn't be in the emergency room for that, you know. And by law, the emergency room has to address it. And so I'm saying that we can deal with that much better at a community health center, and it's a preventative kind of thing because it's no reason that you would need to go to the emergency room for that. The emergency rooms are built specifically for emergencies, gunshots, broken legs, something serious. But many of these things are not serious, and it can be dealt with right at a community health center. That
Oh,
is going to save
now
everybody.
this is a good point, Clarence, to explain the difference between primary health care and urgent care. Could you make that distinction so that the audience understands which is which and why they should not be going to hospitals. They should be going to Hamilton Community Health Network
Yes,
or its lookalike or
absolutely.
another FQHC somewhere in the region.
Mhm. Well, when you look at an urgent care uh, program, okay, you got your emergency room, that's a hospital. The urgent care is more of a primary care, but it only deals with, here again, whatever you come in for. Now, they don't treat that problem, they deal with just that particular issue. Whereas community health centers, we at Hamilton, we address everything. Uh, And so we put you in a program whereby now we're dealing with the whole person. You come in, you may have a problem, uh, let's say with your diabetes. And when we take you through the examination, we may find something else. We may find that you even need some behavioral health services.
Mhm.
But we address all of those things at that visit to determine what are your needs and what do we need to do in terms of sending you to our other programs versus urgent care. They're just going to deal with that problem. They're going to send you out. And hospitals, they're going to
Again, would you explain why people should not go to the hospital? It adds a terrific burden to the debt ratio in the country and to the rising um, Medicaid and Medicare costs.
Mhm.
which is drowning the country.
Mhm.
And like you say, FQHCs were provided to meet the primary healthcare needs.
Yes.
And when you go to the hospital, you go for urgent care for long period of stay. It costs $1,000 a night just to have a room for you,
Absolutely.
plus all of the other diagnostic things that hospitals do,
Mhm.
and the treatment of drugs, the
Mhm.
intensive care of constant monitoring,
Mhm.
etc. Air conditioned rooms. Of course, you have that at
Oh yeah.
Hamilton. Oh, Clarence, I got to speed it up a little bit.
Okay.
We'll come back to this
Okay.
at another time, but you've
Okay.
done a good job. At
Okay.
least if nobody's listening to us, let's assume that.
Yes.
But
Okay.
if they didn't listen, if they didn't get much out of that, one thing they learned is why they should use Hamilton or a lookalike or another FQHC rather than to burden healthcare on hospitals,
Yes. And
which
what
is
people have to
which is
understand,
about
Henry.
3 or 4 times. What is the ratio? What's the ratio of the cost of using Hamilton for primary care and going to the hospital for primary care? Do you know
Oh,
what the ratio is?
well, let's take an average visit. An average visit at a community health center is around $100. Whereas in a hospital, if you go to the emergency room, you could be talking about 1,000 or more.
Yeah.
Okay. Not to mention that if you need
See,
medication,
even that's 10 times what it would cost you just to
yes,
go to Hamilton. 10 times.
yes,
And you get adequate and equal care, the best care.
yes,
I've seen nothing but things that I would praise and admire Hamilton for, and how it carries out its duties and responsibilities to its patients.
yes. So critical.
Well, Clarence, identify two strategies you have implemented to gain the public trust within this community. What have you done particularly that stands out in your mind that other people also see that benefits the community?
Well, again, Henry, I think it boils down to trust and, having uh, the resources and the practitioners to gain that trust of the community. Uh, and we try to do that in the best way that we can. Now, we have programs that can help the medically underserved. Like I mentioned, the 340B program. We have a sliding fee scale for those who may not may make too much to purchase insurance, but too little to go into a Medicaid program. And so we will provide a sliding fee at a much reduced cost for their services. And in some cases, we see people who may not have the ability to pay. And so we see everyone. And I think that kind of trust is what lets people know that we're here for them, not because we're trying to make a load of money or any of that, but
You
we
cannot.
no, we
You're an
cannot.
FQHC.
That's right.
You must get rid of all of your surpluses.
Yes.
Okay. Um, Wonderful, Clarence. Let me ask you. Uh, Hamilton has been heralded as a high functioning FQHC. Um, do you feel, even though you are successful in what you do and your institution is successful in everything it does, you have all of these rules and represents and uh, these rules and regulations and your other documents that help to guide Hamilton through its processes, as if you have a system that cannot fail. Do you believe your system can, is there? Can you improve yourself?
Henry, you can always
Explain,
improve.
because I
Absolutely.
asked to put this in the form of a question
Hmm.
because I don't know what the answer is.
Okay.
Okay.
Yes. Well, I think you can always improve, Henry. And the question is, how do you go about doing it? I think what we have done thus far have been fairly successful, and we want to continue that, but we want to improve upon it. We want to provide more training for our staff. We want our providers to get the things that they need to do a better job. We need a better EMR system, electronic medical record system, and with AI now coming on the scene, we've got to stay attuned to all of the improvements that are happening within the system. I think that's how we stay on that cutting edge. That's how we stay ahead of those things that we need to be ahead of in order to provide the best care that we can.
Clarence, I want to quickly ask you about the SWOT analysis that
Mhm,
you do periodically.
mhm.
Is it every 3 years?
Yes.
Okay. Now, the SWOT analysis is you look at the strengths,
Mhm.
the opportunities,
Weaknesses, opportunities,
and the
and threats.
weaknesses and threats.
Mhm,
Now, um, you're looking at the situation now. Uh, when the country is calling and the president is calling for a reduction of the workforce in Washington. Um, does that impact how would how explain the
mhm,
threats and SWOTs? Go through the analysis for me.
mhm. Well, what we do, Henry, like you said, every 3 years is we look at uh, what are uh, the the threats out there to us. You know, what are the opportunities? What are our weaknesses? And when you look at the system today and you see that funding is being cut, we see in some cases uh, competition is is more stiffer. And so, how do we deal with that? And I think what we do is one, we continue to do what we've been doing. We do what's been successful. We work hard to make sure our patients are getting the care and the services they need. And I think as long as we do that, we're working with our legislators, we're working with the patients that who are really in the final analysis are the ones that's going to determine how successful you are. And I think that is why we've been able to to achieve the things we have so far. But we evaluate all of those things and and we decide, where are our vulnerabilities? Where are we possibly weak and could be hit, and what can we do to prevent it? Now, when you're talking about funding, that is something out of our control as far as grant funding, because the federal government is responsible for that. When you're talking about things like vaccination and where we get our vaccination supply from, and what is that going to look like? Uh, I mean, the people at HHS makes those determinants. CMS, they determine, you know, what that's going to be. Now we just try to follow the guidelines and make sure that our patients are getting the things they need, and we do everything we can to ensure that they are getting it.
On that point, Clarence, I just thought of something. Now, you provide shots and to for many kind of diseases
Hmm.
based upon the um, the data. Okay,
Hmm.
based upon tradition, based upon the law. But why is it that you do not offer shots for HIV, which is very prevalent in this country? Um, and yet you have no way of dealing with it. Why is that?
Well, we
I think it's HIV, isn't it?
yes, yes,
Okay.
HIV, and we have other partners that deal with that. The health department is one of them, and so when we find it, refer those
Okay.
patients to one of our other partners. We don't want to duplicate services. If somebody's providing a service and doing a good job at it, we want them to continue to do that. As long as we can assure that our patients are getting the best care, then we don't want to duplicate services.
Clarence, we gotta bring the show to an end
Okay.
because of this length. But I just want to ask you the final question. Do you have any questions for me? Do you have any advice? We could. No, I should be asking you to give us advice. Okay. What would you like to? How would you like to be remembered, Clarence, as a CEO who helped to found and define who Hamilton is, along with Archie LaFleur
Mm,
and the old members long time ago
mhm,
who had the right people at the table. And they said, despite of the fact that other people, and General Motors and all of the others said, the 5 hospitals were here,
mm,
you guys will never make it.
mm,
You guys are too poor. You guys won't want. But Archie had been a member of the Civil Rights Commission. And, and I was president of the board, but I didn't know much about advocating for
mm,
rights of
mhm,
anybody else. I worked for the man, you
mhm,
know. And, but Archie, I learned a lot from Archie.
mm,
And I have nothing but and the other board members.
mhm.
But when you came in, you helped to really define us. You've lasted 3.5 times longer than we wanted you to. No, I'm just kidding.
Yeah.
No, I'm just kidding. You're Clarence. You've done a great job. You're a good American. You've been a great host. There are other things I wanted to get through, Clarence, and that was the survey.
Mhm,
The survey that I, it took days and weeks to do that survey.
mhm,
And I surveyed healthcare systems around the world
mhm,
in countries that look more like the United States. Um, of the 5 of the most industrialized nations in the world. And I found out, Clarence, and they compared, it was a contrast comparison
mhm,
survey.
mhm,
You compared with the United States and certain areas, starting with GDP and quality performances like access,
mhm,
value, affordability,
mhm,
etc. There were 5 value constituents that we had in the survey. And the results, most of your audience would be surprised
mhm,
what people think about healthcare in the United States.
mhm,
And so, while we need to get better to make sure that we, in a free enterprise system, do reach down and pick up the people who are left behind.
mhm.
And this is not by color. This is how we get characterized by the rest of the world. It's based upon some of it's based upon on race, others based upon um, gender, and others on wealth,
Mhm,
etc.
mhm.
They say we need to do a better job. Um,
Yeah. Well, Henry, I think they all have their strengths and weaknesses.
sure,
Uh, I think we have the best healthcare system in the world. That's my own opinion.
yes,
Uh, because no matter what system you have, uh,
we're a free enterprise system.
with free
This is
enterprise.
why, and many people don't like it because they don't
Mhm,
understand it.
mhm.
But we're the most generous. We have the most generous healthcare system in the world.
Absolutely. And
Yeah.
the most competent. You
Yes.
know,
Yes.
when you talk about fairness, let's face it, no matter where you are, people with wealth are always going to be able to get
Yeah. And
what
we
they
need the
need.
people with wealth.
Yes, we
Yeah.
do. Yes, we
Hey,
do.
Clarence, I'm sorry, buddy. We couldn't get through everything, but you've done a great job. You're a good American, and you should be praised for the job that you do. And we thank you for being the CEO of Hamilton Community Health Network. And we look forward to having you again.
Yes,
As our
thank you.
guest, you've done a great job, and I'm sure we're going to get lots of feedback about the things that you talked about. One, that you should remember why you should not use hospitals if you
Yes.
have a gunshot wound. You know, that sounds bad, doesn't
Well, that's what you want to use it for, but not for primary care.
it? Okay,
Okay.
okay. That's being silly. I'm sorry. But you mentioned it, and
Yes.
I thought that was an urgent care thing, but it doesn't have to be, right?
No, no,
No,
it
okay.
doesn't.
Thank you. I learned something, Clarence.
Okay.
Thank you very much for being my guest today. And I will get some feedback from how the audience reviewed this and reacted to it. We hope they would send in their thank yous and their appreciations to the studio, um, as they would like to see you again on this show to discuss more of these issues.
Yes.
And what we'd like to do, Clarence, is talk about how you build that endowment. We need to build an endowment. There are people out there who want to build an endowment, and I have some recommendations, but I will talk about those privately.
Okay. The
Okay.
only thing I'd like to leave you with, Henry, is for your audience to know how to contact Hamilton. If you
Yes, please.
need an appointment or if you would like a friend, family member, whomever, feel free to contact us at area code 810-406-4246. And our website is hamiltonchn.org. And you can go on there and get all the information you need.
Well, Clarence, we got to leave it there. Thank you very much. And
Thank you. And
folks, the program has come to an end, and we're going to be signing off now. This is Henry Hatter of the Old Opinion and My Opinion Network. Um, and Clarence, good night.
thank you, Henry.